respected senior faculty members at SCOS Jammu, and dear friends, today I am going to discuss a topic which is very relevant in large animal surgery. Though it is considered a complex surgery, but a majority of buffaloes and cattle, they suffer with this. So we know that many a time, means frequently at our clinics, everywhere we are practicing, we are encountered with the problem of digestive system. So digestive system is one of the important system with which we deals. And when we see the digestive system, in that a major disease which is known as foreign body syndrome means a disease which is caused due to foreign body having so many complications, and one of the major complications beside traumatic peritikuloperitonitis and this traumatic pericarditis is diaphragmatic hernia. So diaphragmatic hernia, though nowadays the cost of the bovine species is around a lakh, and even beside economics, being a mankind and the prime species on this planet, our motto is always to saving one animal may not change the world, but it will surely change the world for one animal. This is the motto which works behind why we even undertakes the complex surgeries, and being a human being, to save the life of animal is our prime goal. So just introduction in brief, that diaphragmatic hernia is a serious digestive disorder. Why it is serious? Because if the treatment is not undertaken, if the surgery is not done, 100% death or 100% mortality is sure. So it's a serious digestive disorder in buffaloes and cattle involving the rupture of diaphragm. In simple language, you can say that there is rupture of diaphragm, and through this rupture, the abdominal content pass into the thoracic cavity. Now, moreover, in our place, because the buffalo population is too high, we observe that in every survey that it is more common, means you can say if we perform 600, 700 surgeries in buffalo, we receive around 2 or 3 cattle only. So it is more common in buffaloes than in cattle. However, people from far south in our country like Namakkal, and they are reporting that they are observing more in cattle. But still we have some scientific evidences, and we can say it is more common in cattle. Etiology, in brief, as I told you, and it's for my observation experience that it is the foreign body syndrome, or it is the penetrating foreign bodies which are 95% responsible for this diaphragmatic herniorrhaphy. Means if you are curtailing the incidence of foreign body syndrome, you will also curtail the incidence of diaphragmatic hernia. Most of the time, 95 to 98% of the time, we receive one or another foreign body from the case of the diaphragmatic hernia during laparoscopy. It has been proved by this department that in buffaloes, the diaphragm is congenitally weak in comparison to the cattle, because at the musculotendinous junction, where this right hemidiaphragm, near the ventral portion, where this diaphragmatic hernia mostly occurs near the location of the reticulum, there is less population or less, you can say, concentration of the collagen fiber, as well as an artery, branch of phrenic artery has been found absent in this area. However, that is present in case of cattle. So people have hypothesized that it is congenitally, the diaphragm of buffalo is more congenitally weak in comparison to the congenitally what I can say, cattle. And the predisposing factors mean any factor which is leading to increase the intra-abdominal pressure, like the act of parturition in cases of the advanced pregnancy, when there is more pressure, intra-abdominal pressure pushing the organs toward the periphery, then we say usually we found that 60-70% of cases they are either in recently parturited bovines or they are either in late gestation. So we consider this advanced pregnancy and parturition as one of the common predisposing factors for the disease. So just refreshing the knowledge of the participants, because maybe many of the participants, field veterinarians are also here, students are there also. So if we see from the right side, we can see the arrangement. This is the diaphragm, this is the thoracic cavity. Diaphragm is a dome-shaped structure, and this you can say here it's an entire ruminal area, and this greenery area is reticulum, this is omasum and abomasum. So this reticulum is around this fourth, fifth, sixth intercostal spaces, or you can say sternary, and they are just adjoining to the, if you see from the left side, they are just behind this heart area. So this is the reticulum, this is the rumen. On the right side, there is omesum, and on the ventral aspect, there will be abomesum. So this is just for refreshing your slight anatomy. So our important part to be in field, to be as a veterinarian, is how to diagnose this case of diaphragmatic hernia. That's the case of diaphragmatic hernia, and we can even facilities available for surgery or not, how we can diagnose so that we can properly guide
सर कल आज कर रहे हैं स्टार्ट होना करने लगे
so we can properly guide
ठीक है सर कोई गल नहीं करना
owner or animal owner that how to proceed for further, either go for treatment or sell that animal for the slaughter, whatever it may be. So when an animal with diaphragmatic hernia is reported, the common clinical sign, I will just go for few, that the most common clinical sign, as like other diseases, is there will be persistent, means animal will be gradually it became inappetent to anorectic, and animal usually reported to referral clinics like college clinics. They are usually reported after 15 days, a month or 2 months, that initially it was taking less feed, then now it has become completely off it since many days. But in 90% of cases, you will find that there is either recurrent or persistent tympany. Recurrent tympany is one of the most common symptoms. If you find the case of recurrent tympany in field conditions, it is one of the most common symptoms on which you can go for suspicion that it may be a case of diaphragmatic hernia. Sometimes persistent tympany is also
वैक्सीन की ना उबी ਵਿੱਚ ਕਾਊਂਟ ਕਰ ਲਿਆ 40 ਹੀ ਉਬੀ ਵਿੱਚ ਕਾਊਂਟ ਕਰ ਲਿਆ ਹੈ ਇਹ ਵੀ ਕਿਤੇ ਹੈ ਕਰਨਾ ਸੈਂਪਲ ਦੇ ਸਾਰੇ ਕੇ ਮਲਾਈ ਮਲੂਏ ਕਿਤੇ ਫਿਰ ਆ ਸਾਰਾ
there may be either this peritonitis or there may be either this DH case. If there is simple traumatic reticuloperitonitis, usually that is not persistent, but when there is generalized peritonitis or persistent tympany, there is maybe only either the generalized peritonitis or there is DH. Now, another important symptom I will always say to ask the owner regarding the characteristic of feces. In case of DH, due to longer passes time of the feces in the intestine, there is feces become scanty in quantity as well as pasty and usually blackish in color due to long standing in intestine. So many a time at our place, people say it pass feces like mingan, just like goat and sheep, they call their feces, they used to call it local language like mingan. So it will be very small in quantity and it will be more harder in consistency than normal one, and it will be more darker in color. Now another important feature to recognize is that is a loss of condition, which animal will go emaciated day by day. And what we have observed, though this is not mentioned in any paper or any book, what I have observed, that animals suffering with diaphragmatic hernia, usually they have a sparse hair in comparison to the normal hair. And the hairs which are on their body, they will be more longer in comparison to a normal buffalo or a normal cattle. So this is you can say our observation, still not text. Such animals will be refractory to medicinal treatment. Means if you are giving rheumatorics and this anti-bloat medicine, they will be respond. Again, tympany will occur once they will take the feed and water. And if the animal is lactating, there will be sharp decrease in production. So means 1/3 to 1/4 decrease in production. Sometimes it goes to nil. So these are some important clinical signs on the basis of which you can diagnose. Besides this, if you will ask the history, most of the animal, since it occurs between the 3 to 8 years of age more commonly, so most of the animals, they will be either recently parturited or they will be in the advanced stage of the pregnancy, 7-month, 8-month pregnancy. The disease is chronic in nature, and to differentiate from the other diseases, usually in 99% of cases, there will be no history of fever. So these are the few signs on the basis of which you can go for suspicion or diagnosis. Now, how to confirm it? First, when an animal is presented to you, differentiate it from the few conditions like traumatic pericarditis or traumatic reticuloperitonitis. So if you have, this is a typical case with persistent tympany which has been reported for the diaphragmatic hernia. But in case of pericarditis, there will be brisket edema, there will be tubular engorgement, animal will be sometimes open mouth breathing. In case of peritonitis, There may be some acute changes, there will be fever, as well as pain will be there. So crouching is more evident on that. So these are few, just go for differential diagnosis. Now, one of the important tool to diagnose, and that is mostly located in referral hospital like colleges, that is the radiography, on with the basis of which we can almost confirm the case, our suspicion by diagnosis. Now, this is the way how we go for a diagnosis of the case of diaphragmatic hernia by radiography. It is a standard practice to make the animal on lateral recumbency, because in this position, the FFT, what we call focus film distance, you will have the minimal distance, so we always get a good picture. But nowadays, due to improved condition of this computerized radiographic system and improved softwares, we are also able to diagnose this diaphragmatic hernia or the reticular diaphragmatic lesions in case of a standing animal radiography up to 80 to 90%. But when still we get confusion, we make the animal recumbent, because animal in advanced pregnancy, animal will be having pericarditis. Now, if such animals are made to recumbent, there is more chances of mortality. So in such animals, standing radiography is more effective. But to have a clear picture of this reticular diaphragmatic area, this position is the gold standard. Now you can see that how animal is made recumbent, and along with grid, this cassette has been applied below the sternum and the reticular area. So when we go for this standing animal radiograph, you can see that how we make this limb forward by stretching with help of tying a rope and pushing cassette like this. So this is how the X-ray is taken in case of this diaphragmatic hernia or reticular diaphragmatic pathology to obtain a good quality radiograph. Now, these are the factors we usually consider, that MA around 160, 180 as per the size of buffalo, and KBP around 80, 90, even up, we go sometime up to 100, 120. So for this, you need at least 600 mm machine to reduce the exposure time, because you can see here that exposure time is for 1 second. We try to reduce the exposure time to reduce the radiation hazard. Now, important thing is, once you take the radiograph, what will be the picture? Now, this is a picture of normal bovine, normal cattle or normal buffalo, that how it looks like. Now, this blacker side, you can see this is the thoracic area, because it contains the air, and this is the abdominal area, because it contains the fluid and solids. So you can see there is characteristic line. That line represents the area of the diaphragm. It represents the diaphragm. Diaphragm is intact completely, and it reaches and it touches this sternivary around 6th to 5th, or in between the 5th and 6th sternivary, or you can say around the 6th sternivary it touches. It is a dome-shaped structure having convexity towards the thorax and concavity towards the abdomen. So it touches at this place. So this is very important. This you should have to keep in mind. Then we can only go for diagnosis of a case of diaphragmatic hernia. This is a case, the radiograph of normal, but it is in younger animal. Here you can see we usually use 12 by 15 inch cassettes. So to take a big radiograph, here you can see that even heart, this lungs, and this abdomen is, but this diaphragm line is typically clear, very clearly demarcated, and it touching here around 6th sternivary. So this is the reticular area in normal animal. This is the reticular area. Here reticulum lies, but unless and until there is no any non-potential potential for body, which is radio opaque, means either it is stone-like or some metal-like, then until unless it will not be clear, because all have similar density. Now, how it looks like in, this is a case which has been taken, radiograph has been taken in a standing animal, and you can see here, this is the 7th sternivary, this is the 6th, this is the 5th, and you can see here, this reticulum is containing either so much sand and some non-potential foreign body, and it is located here. So this presence of potential or non-potential foreign body, especially in case of DH, for diagnosis a case of a DH, we always say, when you observe the presence of non-potential foreign body cranial to this 6th intercostal space, cranial to this 6th sternivary, then we can say that this is a case of diaphragmatic hernia. Because if the diaphragm would have been there, it would have been here only. But if it is due to this non-potential foreign body and this reticular fluid content, it is coming like this. So presence of non-potential foreign body in the thoracic area is a clear-cut confirmatory sign of diaphragmatic hernia, even if you are observing diaphragm line or not. You can see here also, here you can see a lady's hair pin, and here this non-potential foreign bodies. However, the diaphragm line would have been like this. This should have been the diaphragm line. So it is cranial to that. Even reticular sac is visible up to this extent. So this is a case of diaphragmatic hernia. Similarly, there are so many cases. So once we see that this non-potential foreign bodies, if you can see here, this triangle-like area, it is representing the diaphragm. Because in lower area, there is no diaphragm. So it is not intact. So reticulum, it is giving the shadow, and this non-potential foreign body, it is in the cranial to the diaphragmatic line. So here you can see the potential foreign body, but this potential foreign body may penetrate without rupturing the diaphragm. But this non-potential foreign body, presence of the non-potential foreign body, it always indicates that reticulum is present inside the thoracic cavity. So this anatomical concept is very important in diagnosis. Here you can easily see how much this reticulum has gone cranially, what the cranial extent of the reticulum is. You can see 7, 6, 4, 5th, 4th, 3rd, even up to the 2nd. Here up to this level reticulum is there. So these all cases you can see how it is a cranial to the this 6th one. So these non-potential foreign bodies are present in the thoracic cavity. So though all are representing the diaphragmatic cases of diaphragmatic hernia, they are the confirmed cases of the diaphragmatic hernia. However, this potential foreign body, they may penetrate here or there, they may forward, they may progress even without the rupturing. But the presence of non-potential foreign body, it is a clear-cut confirmatory sign that it is a case of diaphragmatic hernia. Now, the difficulty in diagnosis with the diaphragmatic hernia in case of radiography is chest pathology. Like suppose this is a case of hydrothorax. Now in hydrothorax, because you can clear-cut see here the line of the fluid. So if that here in thoracic cavity also lower ventral aspect, it is also fluid, in abdominal cavity is fluid. Even the reticulum has not penetrated, but the diaphragm will be absent. It will not be seen. So because there is no change in the density on both sides, there is similar density on the both sides. So muscular structure of diaphragm will not be seen. So these are the hindrances in pathology, hindrances in X-ray, where we are not able to diagnose the cases of diaphragmatic hernia. Similarly, like cases of nodules or cysts in the lung, when they also give the opaque radio density of the lung area, so they make the diagnosis of diaphragmatic hernia difficult. So in such cases, it is always advisable that go for the contrast radiography. Give animal 5 to 10% barium meal, almost half liter to 1 liter. It will go and it will outline the reticulum clearly, and we will be able to see the diaphragm, reticular position and diaphragm. So reticular outlining and bone will be easily clear after that contrast radiography. So you can easily say it is a case of DH or not. But nowadays we have shifted to another technique, that is the sonography. And in sonography, though people sometimes ask the question, can we diagnose a case of foreign body when lying in the reticulum by the sonography? No, we cannot diagnose. But how we diagnose the diaphragmatic hernia? Because in case of the sonography, it is very clear, or it is very easy to diagnose the outer area, the wall of the reticulum and the changes in the peritoneum, which you cannot diagnose with help of the radiography clearly. In radiography, it is difficult to diagnose a case of reticular adhesion. It is difficult to diagnose a case of hydroperitonitis or peritonitis with fluid in the peritoneal cavity, or it is difficult to diagnose a case of adhesions or fibrinous bands. However, in case of sonography, it is very easily diagnosed that you can see the increased quantity of fluid in the peritoneal cavity. You can see that this reticular wall and the diaphragm, they are being adhered with the help of these fibrinous adhesions. So, and the presence of reticular movement, reticulum when seen from the this sonography, you can see it is a semi-lunar structure which sees the typical movement as like ruminal movement. It will go downside with each reticular movement. We know that reticulum is, there is a ruminal reticular movement is biphagic. So with each movement, it will go downside. This semi-lunar structure will go downside and sometimes disappears. So this is diaphragm. So we can easily reticulum. And when we are able to diagnose this reticular motility by seeing the reticular wall at the level of fourth intercostal space by sonography from the right side, just 4 to 6 inches above the sternibry, we can confirmly say that yes, it is a case of diaphragmatic hernia. At fifth, there is confusion. At fifth intercostal space, though some people say that we can diagnose, but we have matched that result with the X-ray and the surgical findings. We found when the presence of reticular wall and reticular motility is at the level of fourth intercostal space, when we take from the right side, right lateral side, then it is a confirmed case of diaphragmatic hernia. Now this is a, just you can see, this is the movement, wavy line movement you can observe with help during each respiration. But this is a typical appearance of the reticulum which move with each reticular movement. It goes downside, and by this, the location of your transducer is important for diagnosis. When it is on the fourth intercostal space from the right side, we can just say, yes, it's a case of diaphragmatic hernia. And please remember that's a very useful tool in case when there is lung pathology, when there is animal is in advanced pregnancy like 8 months, 9 months, and to make that animal recumbent on the right lateral make that animal recumbent on the lateral side is very difficult. That may lead to sometime abortion and like that. So in such cases, as well as in cases where there is reticular abscess, where there is reticular adhesions, where there is peritonitis, this sonography has been very useful. So it can be used as a supplementary tool and diagnosis where radiography is not available. Now, beside this, though these laboratory examinations are not important, so not so important to give a typical clear-cut diagnosis, but they may be helpful in supporting your diagnosis. So, in case of hematology, early cases, there is TLC is in normal range, and neutrophilia with left shift, which means the more immature neutrophils will be seen. And as the case becomes chronic or as the history is prolonged, these also neutrophilia disappears. However, usually in 90-80-90% case, we see that this neutrophil and lymphocyte ratio is reversed. Because many people, they just confuse ki dog, just like dog, ki there is more neutrophil. In bovines, it is always to be remembered that the lymphocyte is more in normal animal in comparison to the neutrophil. However, in diaphragmatic hernia cases, mostly we observe that neutrophil becomes more in number in comparison to the lymphocyte. So that ratio is reversed in pathological condition. If you analyze for the electrolytes, there is usually hypokalemia, hypochloremia, and hyponatremia. And usually these animals took less feed and water. So usually these animals are emaciated and dehydrated. So total plasma protein, they remain on higher side. Along with there is just one typical sign is because there is some immune response is going on. So there is increase in globulin in comparison to the increase in albumin. Now, more than this hematology and biochemical, these rumen profiles, they are more supportive. If you get ruminants or go for ruminocentesis and get the rumen fluid, and if you go for checking the pH, it will be lower pH than 6 in case of the diaphragmatic hernia also. So pH will be on lower side, or what we can say even buffering capacity. Then infusorial count means the quantity of bacteria and the protozoa which we can see below the 10x completely moving, and a number of flagellates and the bacteria moving below the 10x, they will be very less or they will be dead. And as well as this volatile fatty acid and ammonia content of, if you have the facility, you can measure, they will also be lesser in number. So our important procedure or our important part will be how to treat such animals. So if you are going to treat such animals, there is two-step treatment. Usually we plan it, the treatment in 2 days because it suits our condition as per the office timing, college timing. But usually you can say that there is two-stage procedure. In first stage, we go for laparorhumatomy because by this laparorhumatomy, we evacuate the contents of the ruminal reticulum. We almost completely evacuate. 98% you can say almost we completely evacuate 98% of the content to make the space for the further surgery and to prevent the regurgitation on the day of the diaphragmatic hernia. This is the purpose of the laparorhumatomy. By laparorhumatomy, we go for creating the space inside the abdominal cavity as well as we check the regurgitation at the day of diaphragmatic hernia. So this laparoscopy is performed under the regional block by given 2% lignocaine injection at the paravertebral block at the level of that I will show you in picture. Then next day we go for the, after doing this laparoscopy, we do not provide anything orally till the diaphragmatic herniorrhaphy is performed. Because between these two operations, animal is not given anything, water or the feed orally. We check all this and we maintain the animal on the fluid for the next 12 or 16 hours. Then next day we go for the diaphragmatic herniorrhaphy, and this is somewhat little bit complex because it involves the general anesthesia, which is, as we know that these ruminants are poor subjects for the general anesthesia due to their large viscera and poor stomach. They are usually have been a poor subject. And so for this diaphragmatic herniorrhaphy, though people have sometimes claimed in conferences that they have done in local, but if you will see the success rate, there will not be, and that surgery is not even the human from pain point of view. So usually it is recommended that general anesthesia along with controlled or assisted ventilation is required for diaphragmatic herniorrhaphy for having a good success rate. So we usually, there have been a lot of research that has been done for this diaphragmatic herniorrhaphy anesthesia, and with many balanced anesthetic protocols has been tried, and in that, I can say that the pre-anesthetic which has been tried, they are either atropine or glycopyrrolate, and analgesic, mostly this portwin, that is means this opioid analgesic butorphanol and portwin, they have been tried, and in sedatives xylazine, diazepam, and these tranquilizers that phenothiazines like Cipil and other drugs, they have been tried. For induction, propofol, thiopentone, even we have tried etomidate or combination of xylazine ketamine, and for maintenance we have tried all these three gases, isoflurane, sevoflurane and halothane. But out of that, the most suitable and cheap combination with least minimal effect, suitable for our Indian condition, we have found that atropine, propofol and isoflurane along with butorphanol as well as xylazine for sedation to make the animal restrained. So these have been one of the most suitable condition, a suitable combination of balanced anesthesia, which we follow routinely. Beside research problems, we follow usually atropine, propofol or thiopentone, isoflurane along with this butorphanol and xylazine sedative. So this is the common protocol which you can go for, and that is very easy and very effective. And with this combination, we are able to achieve 95 to 98% of the success rate since last 2-3 years. Now, how we proceed for the surgery? So first stage, that is laparoscopy. So whenever an animal is reported, first we ask the animal go for completely cleaning of the animal with water jet, then preparation of the site, that is left paralumbar fossa for the aseptic surgery. Then we go for this paravertebral block. Now you know that in this paravertebral block, there are 3 nerves are blocked, that is T13, L1 and L2. Now there are 2 methods. This is the proximal method, or what you can say Fatih-Hassan's method, where on the proximal transverse ridge of this first lumbar transverse process, this 13th thoracic nerve is blocked, and it is blocked just 5 to 6 centimeter lateral to the main median plane on the left side and on the anterior margin of the first lumbar transverse process. Similarly, the second is blocked at the level of the 6 to 7 centimeter away from the median plane, and the L1 is blocked here and L2 is blocked at the third lumbar transverse process. Similarly, it is little bit, it needs more precision. The people who are doing daily, they can do it within do it with much precision and with less local anesthetic. However, for beginners, it is more convenient to go for the modified Cambridge method, or what we can say the distal paravertebral block. In this, what we do, we take this anterior lateral margin of this first lumbar transverse process and make this needle to go below the skin first, because this every nerve have become two branch. One is superficial and another one is deep. So first we block the superficial along the lumbar transverse process along its upper border. Then we go little deep and we block the ventral branch to block the supply to the muscles. Otherwise, you will have blocking the cutaneous supply, but muscles will give the sensation. So this is more useful for the beginners. Then after this anesthesia, paravertebral block, we again go for the last scrubbing, and after last scrubbing, we go for the preparation of site by draping. This is the animal which I have intensely taken because this is being laparotomy is being performed for the second time. You can observe this remnant sign of this scar of this first surgery. So after this, you can go for surgery by draping like this. Then make the skin incision with help of your blade. We take the incision line. In case of buffaloes, it is always better to make the incision in the mid left flank area, mid paravertebral left fossa. However, in case of cattle, it is always better to be more cranial and just you can say 4 to 6 centimeter caudal and parallel to the last rib. So in cattle, the incision is little bit in the ear, and in buffaloes, we make incision parallel and caudal to the last rib. Then after making incision or skin incision, we go for incising the muscles with help of the scissor. We go for incising the muscle with help of there are 3 muscles, 2 are oblique and 1 is transversus abdominis. After incising, you have to incise the parietal peritoneum. Otherwise, some people they get confused that there is adhesion. But first you incise the parietal peritoneum, then you will see the glistening content which are moving freely inside the abdominal cavity. So after this incising the parietal peritoneum, we fix the Wingard ring here by help of the screw. Below we apply the hook below the skin and we tighten the screw. Then after this we take out the rumen with help of a sterile shroud or sterile drape and fix here with help of the rumen forceps along with after the application of a sterile gauges, because this will check the trauma to the ruminal wall. Then after this, we pack this remnant space with another shroud or another drape between the rumen and the line of incision to check any leakage or to prevent any leakage from entering the peritoneal cavity during the runotomy. So we make another packing below between the rumen as well as the line of incision, that is muscles and the skin. Then you can see here the packing. Then after that we incise the rumen by our BP blade and fix it with the rumen hooks. At least 6 hooks are required. You can apply 8 hooks, 10 hooks, but at least minimum 6 hooks, rumen hooks should be there. Now you can see here, since a delayed case is always presented, the rumen papillae, they have been almost degenerated. Sometimes there is deepethylation we used to see here. Now, there is one important finding that in case of this foreign body syndrome, when there is no diaphragmatic hernia, only the peritonitis is there due to presence of any penetrating foreign body, usually means 90% of cases you will find dry content. Impacted rumen will be impacted because there is atony and the water content gets absorbed and rumen remain impacted. So we will always find this dry content. However, in case of DH, even before putting your hand inside the rumen and the ring, you can say, yes, it's a case of DH because there is hypermotility of rumen because there is no adhesion of the rumen. So it's go on churning the content and the gas and the liquid, they are all mixed. So they are always like froth. So most of them, though you may find this in case of diaphragmatic hernia also sometimes dry content, but that is very rare. Most of the time you will find content like this frothy content, and we have to remove this frothy content. So we remove it partially, then we go for siphoning like this for easy removal and faster removal to complete our surgery in lesser time. So this is the way we apply a pipe, one end of pipe inside the rumen below the content. and with another we make a siphon and drain all the content. Then most of the time when we put our hand inside the rumen, we have to put your complete hand up to your shoulder inside the rumen to reach the ruminoreticular space or to reach the ring and go inside the reticular in the thoracic cavity. 99% of time you find one or another penetrating foreign bodies. These are just few how we find the penetrating foreign body inside the reticular space. Sometimes these penetrating foreign body, they pass even the reticulum and go and lodge inside the thoracic cavity that we may remove during the diaphragmatic herniorrhaphy. So after all cleaning and this preparing the site again for the asepsis, we go for double layer inverting suture. Initially we were inverting the suture with 3-number chromic catgut, but nowadays we are using this 3-number PGA is available, and the economics is no matter. The economics is almost similar. The cost is almost similar in both way. So it is better to nowadays we go with PGA. So we go for the double layer Lambert and Cushing, or double layer Cushing means double layer inverting suture for repairing the rumen. Then once the rumen has been repaired, we go for repairing the muscle in double layer by using 3-number this PGA with help of this lock stitch sutures, lock stitch pattern. Then once these subcutaneous layers up to the subcutaneous level they have been repaired, we go for nowadays we are using here skin staples, but this you can also use the silk or nylon on the skin level for the horizontal mattress suture. So next day we go for first giving the animal atropine. After 10 minutes we go for giving the animal butorphanol as well as xylazine, and after giving the xylazine, after 10 to 15 minutes, when animals become little bit sedated, we go for restraining the animal and make it into the completely dorsal recumbency and go for giving the induction agent like propofol or thiopentone or xylazine ketamine, whatever it may be, go for giving the induction agent. Then we pass the endotracheal tube, 20-number endotracheal tube, 20 gauge or 22 gauge, and this is our large animal anesthesia machine. So along with this, we connect with the oxygen supply. This is how, and we also go for, now we have monitors are available. So we also go for checking the monitors. Both this can be applied on tongue as well as on the vulvar lips. So you can see, then after once the animal is in GA, we either keep the animal on ventilation or we keep the animal on the manual assistance as per the convenience, what we feel seems better to us. However, mostly we prefer manual assistance. Here we are giving ventilation. So any of the way can be, and this is a semi-closed system. Here I can show you that a pop-up valve. This is the pop-up valve which we keep at least open when we are putting on the ventilator. So gas is kept around 6 to 8 liters per minute, and here you can see that we are, because propofol effect just is wean off very easily within 5-6 minutes. So we have started from the just bolus of the isoflurane, means 5% concentration is first given, then we will slowly lower it to 1 and 1.5%. Then after this, the surgeons who are ready for this, they will go for making an incision, this 6 to 8 inch incision behind this gyphoid region. This post gyphoid 6 to 8 inch incision is given on the linea alba, and here you can see some video that after skin incision, these muscles are incised from the linea alba. There is very least bleeding or almost no bleeding, and the adhesions of the reticulum along with the diaphragmatic wall, along with the thoracic cavity contents, and from the side organs, it is separated. Sometimes foreign body is encountered in the adhesions, they are removed. So this is the most critical thing which has to be done. It has to be done very meticulously so that no lung piece or even the heart, pericardium, it should not be broken. We try to retrieve it and we try to break these adhesions very meticulously, that only adhesions should be broken with help of the fingers, not the other structures should be torn. So this is how we go for surgery. You can see here that how this is a reticular diaphragmatic rent, or you can see hernial ring inside a live animal. It has been taken with very difficulty. How when an animal is not treated, this is a case which has been in postmortem, but this has not been treated. How it looks like in normal case, that diaphragmatic hernia. You can see whole of the reticulum, almost some portion of the rumen. Here you can see the spleen. So it has gone inside the thoracic cavity. This is postmortem specimen. However, this is a live animal. Here in live surgery also, I will try to show you the ring. Here you can see the ring. This is the ring in a live animal. This has to be repaired. The edges of this ring has to be repaired, and that we repair with 3-number silk. Double threaded 3-number silk is used for making here lock stitch pattern to repair this ring. This taking and bites are taken in the good muscles, so that should be retained, and it is easy to close that. Nothing is any extra mesh or anything is required. It is easy to close with double layered, double threaded 3-number silk, and the pattern we use is lock stitch pattern. So this is how it is repaired. Then after that, skin and muscles are repaired. Peritoneum and muscles are repaired again with 3-number. Peritoneum is repaired with 3-number PGA, and the muscles are repaired with 5-number polyester. Now it is available. 5-number polyester is available. So with this in continuous pattern, we repair the muscles, and skin we are using at present skin staples. So this is the way. This is the old picture. So it has been seen. This is beside this, the one thing I forgot to tell you, that once we completely close the diaphragm, we put a needle for thoraco, you can say creating negative pressure, thoracocentesis needle inside the thoracic cavity for creating a negative pressure, and this connect this needle with the suction, that is 25 millimeter. My mercury pressure is kept in the suction machine, and it has been kept because after closing the diaphragm, we suck all the air from the diaphragmatic thoracic space to make their negative pressure to facilitate the respiration, the self-respiration of the animal. So this is also an important step. So after once this swallowing and this puffing reflex they are returned, we remove the tube. Then animal is made recumbent in the lateral or ventral recumbency or sternal recumbency. Then after that, animal 5 to 10 minutes animal takes to in getting up. But that is important that you have to ask the owner to at least 3-4 owners to support the animals when it is getting up, because if they will not support, animal will again fall down and it may lead to fracture, because we are doing at the pakka floor. So 4 or 5 these owners they support the animal from the head, from the tail to from the lateral side. Once the animal is able to stand, keep standing at least for the 5 to 10 minutes. Then after that, make animal slowly walk. I will show you the video to move outside this operation theater. Now this is the way how we go for distal blocking of the paravertebral, distal method or modified Cambridge method. We go on this transverse process from the dorsal side of the transverse process, first transverse process, lumbar transverse process. Once then we go for the little bit deeper for the ventral branch of this T13. So we block T13, L1 and L2 at the transverse process of the L1, L2 and L3 respectively for these 3 nerves to block this whole left paralumbar fossa. This is the ring that these 2 edges has to be opposed. This is the suction machine. What I was telling, how we go for suction. We go from the right side and the 6th intercostal space. So we go for sucking all the airs. This is our suction machine, and this is with the help of the IV set. is a 6-inch long needle. It is penetrated here aseptically. Then the bubbles in the bottle, they indicate in the water that air is coming from that or not. And this is performed once the diaphragm has been closed completely. Now you can see he's started giving manually. He's giving we have stopped the ventilation and we have started giving manually. So in manual, there is facility that you can wait, you can increase the interval, you can decrease the interval as per the requirement. Now you can see that after once the animal is recovered, then we go for asking the animal owner to massage all the area where the ropes were tied for too long, 1 hour or 1.5 hours. So he's massaging with any oil just to improve the circulation, to make or help the animal in standing. So once the animal will stand, they will support. These are the owners. So they massage all the areas of the all 4 limbs where the ropes were tied. Now, this is how we have to support. Just we have to support the animal in getting up. Just little bit support is required and keep it standing for at least 5 minutes so that it will regain its consciousness and put its limb properly. And animal itself will start moving. Now you can see here. Now they will tie a cotton cloth to protect both the incision, both paralumbar as well as the ventral incision from the dust and dirt. They are taking a old bed sheet. So they have tied this bed sheet to check the contamination, and now they are taking animal out of this large animal operation theater, and they will go for offering greens and water, some jaggery for little energy source. It is a little bit slopey floor, so that's why they are checking it should not fall. After half an hour or 1 hour, if the animal is started grazing, then you can offer some jaggery along with camphor for the starting ruminal movement, and you can offer the half bucket of water, 4 to 5 liters. You can offer the greens, 2-3 kg. Means we have to offer the feed slowly, not at a time, and we keep this procedure for next 7 days, because we ask the owner that go for feeding the animal in more frequencies but lesser in quantity. Go for every 4 hours, every 3 hours, every 6 hours, you go for feeding, and go on gradually increasing the both water as well as feed in your animal diet. And this procedure in around 7 days, all animal achieves its ad-lib intake. Then along with that, the antibiotics, usually we go for giving DCR, that is dicystine streptopenicillin 2.5 gram morning, evening, analgesics like Melonex for next 3 days, and antibiotics for next 5 days. You may provide some rheumatorics and ask the owner for go for antiseptic dressing till the wound heals, even after the removal of suture. Removal of suture is advised usually after 2 weeks, and during that wound is kept closed along with either some dhoti or cotton cloth like bed sheet or dhoti like that, and keep that cleaning that dressing material or covering every day and changing that. Then animal usually returns to production after 15 days to 20 days, and it go on getting it gets its normal as per the chronicity of the problem. It gets its normal position. So it's a very easy thing, and it can be done everywhere. So with this, thank you very much everyone for just having a patient hearing.